Now, if you're taking an indirect approach or you're working with someone that you have basically just met, or they are super sensitive or they just had surgery and you want to progressively work towards direct therapy for the carpal tunnel, work on the associative problems so that thoracic stability and strength is usually not there. And so what we do there is a lot of the same push-pull movements. We'll link also the video that Brooke did on thoracic outlet syndrome, because approaching that in coordination with carpal tunnel syndrome produces greater results almost all the time. One of my favorite things to do for that is to look at what's known as the serratus posterior inferior muscle. So basically it combines retraction of the scapula and depression at the same time. It's right about through here, kind of goes down in at an angle. And what I like to do is a little finger positioning like this. My shoulders back and down, of course pelvis forward, proper body mechanics. And I just look for that inferior scapular border, or the bottom part of the shoulder blade. And I do about a 45-degree angle and try to aim for her center line. And I just kind of sink forward with my hips. And I can just shift and go a little bit lower each time. Once again, if the person has a hard time with scapular retraction and depression, work towards that directional flow when you're treating the area. Get the muscles used to engaging in that direction, and it tends to create a parallel in what they practice outside of the session. So when it comes to the anterior neck, if we're looking at scalings and things of that sort too, that you definitely have to establish a rapport with your client and make sure that they know what's going on. But a great way to approach that is to have them, if you please slowly get up and then turn around and let your head rest right here. You can take the opposite position on the chair. And this is where your stretches or your myofascial release techniques can come in super handy, where we'll have them slowly turn their head to the left. There we go. And we can anchor. Have them do some deep, slow breaths. And maybe do this for a session or two if you have time at the end. Don't have them move back and forth between positions more than once if you can help it during a chair session especially. Otherwise, it's just not as relaxing. But we can go in through here, do this for a few sessions till it warms up. When you feel, if you're confident with the techniques and you want to do direct pressure applications for the scalenes, just make sure you clearly communicate with your client what's going to be going on. Because if anyone's ever had a finger pushed into their scalenes unexpectedly, you know that's like the worst way to start out a touch interaction. And so we can go in through there. And are you comfortable with this? Mm-hmm. Okay. And what I have them do is I have them retract their chin back just a little bit. Almost imagine that they're growing tall through their crown, just to make sure it's in the proper range of motion. So once again, we'll go more into scaling techniques for chair later on, but oftentimes when it comes to carpal tunnel, you'll get a repetition of the crick in the neck. Oh, I slept on my neck wrong. It's hard to check traffic. And so we can also treat that from here. So if we were to take about 2 or 3 fingers, go through the rest right through here, start at the base and have them slowly turn their head. As you kind of traction and pull up, you can get some awesome work done through here. And if you can take care of someone's crick in their neck before the end of the day, before they have to drive home through who knows what for traffic, they'll remember you and they'll be happy with you. So from there, I'm going to have you slowly stand up and face Amelia. All right. One thing that you can teach them, and it acts as a stretch and a strengthening technique at the same time, is basically what I like to call the goalpost. You're going to have them bring both arms up, okay, 90-degree angle, preferably here, and down there. The struggle during this movement is to maintain that angle, especially through here. And what you're going to have them do is you're going to have them rotate. Imagine that they're hitchhiking, okay? Like that. You're going to keep on externally rotating the arm, and then simultaneously you're going to have them squeeze their shoulder blades together and then depress them down. And if you notice that angle changed right here almost right away, try to get them to keep the shoulders down but the elbows up. That will really work a weak line for this issue. It's the one that's weakened and kind of numbed or desensitized due to excessive internal rotation. And so what they can do from here is kind of do a little push out, internal rotation, pull back, external rotation. And as they squeeze this back here, if they feel a sharp pain in their low back and it's kind of jamming everything up in there, have them do what I call the John Wayne tilt, where they hunker down, or three-point stance, and then they kind of bring their hips up a little bit. Okay, you got that? That'll take the pressure out of the lumbar spine. That can be in and of itself an entire treatment to teach them how to do that. If they're at a desk, it's especially helpful, but that's not what we're going to focus on today. So just bring it back and forward. And I'm going to have you turn around so they can kind of take a look here. Try to do the same thing. Perfect. Thank you. So you're going to reach forward. Other way. There you go. Pull back. Try to keep the 90s and then activate right through there and down there. Okay? Two very underdeveloped and usually numbed up muscles that contribute to carpal tunnel syndrome, even if indirectly. So once again, this is also something you can do against the wall if you want to come over here. If they feel like that, if you want to turn around, that space or that lumbar spine is too unstable, just have them go against the wall and then try to do this against the wall. It's a lot more difficult, but the increased instability for the spine can oftentimes allow them more control.
Really isolate it.
Yeah, it gets it pretty good. But once again, if someone has never had this worked on before, it gets it really good to the point where it can almost transition into pain. And once again, like, pain is a warning system in the body. And oftentimes, if you've had chronic pain, it's firing off for no real good reason. It's just been trained to over-communicate. And so we want to ride that threshold of just enough pressure and intensity or range of motion to challenge its resting state, to give it the catalyst to change and adapt, but not to the point where we're just beating the crud out of it. Because as we'll go over in other videos, that actually violates certain physiological laws and numbs the patients up and makes it so they can't utilize and recruit what we're trying to open up and release. So that's it for this evening. Thank you very much for joining us, and I hope you make it a great day.